Welcome to the American Shoulder and Elbow Surgeons Introductory Curriculum for Fellows. This program was designed by Dr. Masoka, Dr. Gupta, Dr. Levine, and myself as an 8-week review of the fundamentals of shoulder and elbow surgery. And we really hope that everyone listening tonight will learn and enjoy. The topic tonight is rotator cuff tears, evaluation and decision making. And I cannot think of two better speakers for us tonight than Drs. Jed Kuhn and Dr. Jay Kinner. They are both incredible researchers. As you will see, they are very engaging presenters as well. And in particular, in the field of rotator cuff disease, they are authorities. Dr. Kuhn has been instrumental in multi-center prospective randomized studies in this field, which is extremely difficult to do, and he's been incredibly productive. And Dr. Kinner has published the most interesting information I know about the natural history of rotator cuff disease. So we're really, really grateful that both of you are with us tonight. For the fellows, as you know, we love interaction. So please use the chat window. We will be looking at it and we will ask any questions you may have to our panelists, because this program in the end is for you. So Jed and Jay, whenever you guys are ready, please take it off and we'll be here asking you a few questions.
Thank you, Joaquin, and thank you, Bill Levine, and everybody else for this opportunity. I'm sure Jed and I would very much are very excited to talk about a subject that's near and dear to our hearts, and for which we spent a lot of time studying and trying to understand. And there's a lot of unanswered questions still, but it's always good to review the fundamentals. So. With today's talk, our goals are to provide clinical pearls regarding the evaluation and treatment of degenerative tears and establish a foundation for thoughtful treatment algorithms. So the majority of tears that we see are degenerative tears. The risk factors for these are aging, hand dominance, and genetics, which really haven't been fully defined as of yet. We do, however, see some traumatic tears, and truly traumatic tears are pretty rare. This implies trauma to healthy tissue. More commonly with the traumatic tears, what we see is an acute on chronic a situation where you have a minor injury on top of pre-existing disease. So why do people get cuff tears? It's usually a combination of intrinsic and extrinsic factors. The intrinsic factor theories are more popular these days. Basically, this relates to senescence or aging of the tendon. If you look in the rotator crescent, there's a critical zone of hypovascularity that predisposes to degeneration as we age. Further evidence suggesting intrinsic factors includes the high incidence of bilateral disease and asymptomatic tears, and the poor association with occupation and physical activity for the development of these tears. There are some extrinsic factors. Most commonly, this concept of impingement, which relates to acromial osteophytes. Some authors talk about critical shoulder angle or acromial index being risk factors relating to impingement. Scapular posture is important as well. A poor scapular posture or a hypokinetic scapula can lead to impingement at earlier arcs of motion, and that's kind of one of the fundamental goals of rehab for non-operative treatment. Other extrinsic factors include microtrauma, such as repetitive sports or overuse. One of the seminal articles relating or describing the correlation of degenerative tears with age was done by my partner and mentor, Dr. Yamaguchi. He did an interesting study where he looked at close to 600 patients with unilateral shoulder pain, and they performed bilateral shoulder ultrasounds, and they found that about 36% of patients had a full thickness tear in their contralateral shoulder, but no symptoms. And 21% of them had partial tears. And if you look at the age distribution, if you present with a unilateral painful shoulder and you're 66 years of age or older, there's a 50% likelihood that you have a tear in your opposite shoulder. So the cascade of disease ranges from tendinopathy, which is degeneration of the tendon, to partial tearing, to full thickness defects. And the number one feature or factor is time, and that time course is probably variable from patient to patient. So one of the fundamental questions is, what is a degenerative rotator cuff tear? And it's important to look at the superior cuff anatomy. So Dr. Burkhardt described the rotator cable, and just lateral to that tissue is the rotator crescent. And this is the thinner tissue that has poor vascularity. And when Jed and I were training, we were taught that the majority of rotator cuff tears actually start immediately posterior to the biceps tendon. But much of our research has shown that a lot of tears, most tears initiate about 15 millimeters posterior to the biceps, and they propagate in both directions. So if you look at our ultrasound mapping studies for degenerative tears, the majority of them are what we call cable intact, which means that the tissue on the front edge of the supraspinatus is intact. And these tears, which are seen about 70% of the time, have much lower risk of muscle degeneration as opposed to the larger cable disrupted tears where the biceps tendon is uncovered, the supraspinatus pulls off, and these tears tend to be larger than the cable intact tears. And these tears also have a worse natural history in terms of not tear enlargement, but the development of fatty muscle changes. When we think about classification, the most common classification for partial tears is the Ellman classification, and he tended to stratify these as articular or bursal-sided tears, and then they were subdivided according to the depth of the tear. So 6 millimeters or greater would be considered a high grade or a grade 3 partial thickness tear. In terms of full thickness tears, the most common classification that we use was proposed by DiOrio and Cofield. And these were divided into small, medium, large, and massive tears based on size. Refers to the greatest dimension in either plane. And the other two common classifications for a massive tear would be a complete two-tendon tear or a tear of any size that's chronic and retracted to the glenoid rim. Lafosse probably has the most useful or commonly utilized classification for subscap tears, and the type 1 and 2 tears involving the upper third of the tendon, type 3 tears involving the upper 2/3, and then the type 4 and 5 tears involving the entire subscapularis with or without head decentering. So this classification is useful and for subscapularis disease. I really like this classification for massive cuff tears, the Collin classification. Philippe Collin in France subdivided the rotator cuff into 5 components, and he described massive tears following into these different patterns. So you have the supraspinatus, the infraspinatus, the teres minor, and then the 2 quadrants of the subscapularis. And this classification is helpful not only descriptively, but it also predicts function to some degree, and it highlights the importance of the inferior subscapularis in maintaining a well-balanced shoulder. Next, Dr. Kuhn's going to talk about the history and physical exam.
Thanks, Jay. So hopefully you guys understand these concepts. They weren't really taught to us when we were in medical school very well, but hopefully you guys have a little bit more of this than we had. When we look at tests, and that's MRIs, X-rays, physical exam tests, they have 2 characters. One is accuracy and one is precision, and they're very different. You can think about it like a target, like on these slides. When all the bullets are clustered together, it's precise, but if accuracy, but poor precision. The third picture is what we want, and then the last one has poor precision and poor accuracy. Next slide. And so we can figure this stuff out by looking at the 2x2 table. And again, I'm not going to go through this in great detail. I know you already had a lecture on physical exam of the shoulder, but if you've never played with the 2x2 table, take a paper that was designed to talk about a physical exam test and then put it into this paper and do the calculations, because it really gives you an intrinsic feeling for what these features are. When you do these calculations and you try to see when the test is positive and the disease is positive, or when the test is negative and the disease is negative, and you calculate sensitivity, specificity, accuracy, all these different things, probably the most important feature of a test is something called the likelihood ratio. What the likelihood ratio is, how much does the test change the probability of having the disease if the test is positive or negative. So go ahead and next slide. Precision is different. That's accuracy. Precision is different. Precision is when I compare my exam on one day to myself on another day, or when I compare my exam to Jay's exam, which is always going to be better than mine, because I don't believe in exams very much, and I'll explain why. But anyway, these are inter-observer and intra-observer agreement. And we talk about kappa values, which are kind of arbitrary cutoffs. But if you really want to have good agreement, you're looking for more than 50% agreement or 60% agreement. And you can see the kappa values, almost perfect is 80% to 100% agreement, but we almost never get there. So just to give that as a foundation, we'll start to look at some physical exam tests. With regard to the history, the mechanism is really important. As Jay talked about, there are 3 or 4 different ways of classifying rotator cuff tears based on the mechanism. You can have chronic atraumatic cuff tears. These are people that come into your office with pain, no history of trauma. They brought an MRI that shows a rotator cuff tear. You can have acute traumatic rotator cuff tears. We'll talk about each of these individually. That's a different animal completely. And then there's one that's in between, and that's the patient that had cuff disease or a small cuff tear and had a minor injury and their cuff tear enlarged and they had more symptoms from that. With chronic atraumatic cuff tears, typically these patients don't have any history of an injury. They often come in saying they have trouble sleeping, they have pain with activity. If they're just sitting in front of you, they typically don't report a lot of pain, and they often don't have much functional loss except that what limits them by the pain that they have. Next slide. So this is a systematic review we did trying to look at historical features in people with chronic atraumatic cuff disease, because every element of the history changes the probability of having the disease, right? If I mentioned to you a 50-year-old lady with no history of shoulder trauma and diabetes and bad shoulder pain and stiffness, those features are all elements of the history, but you're already in your mind are thinking adhesive capsulitis. So the history can be like a physical exam test, and it has likelihood ratios as well. And when we look at atraumatic rotator cuff tears, things like male gender, age greater than 60, age greater than 70, BMI, seem to have pretty big features. The likelihood ratio, if it's close to 1, it doesn't affect the probability at all. So if you look at these historical features, the things that really stand out are people that are retired, people that are age over 70, people that are age over 60. And a history of trauma can be there as well. Hypercholesterolemia, interestingly, has a positive likelihood ratio of 2.3. So these are historical features. There's a lot of data we need to continue to get to really have this stuff. But someday a computer will sort all this out and we'll be able to diagnose rotator cuff tears. These are papers that I really love. We can't do this in the United States. These were done in Germany. But Christian Gerber took hypertonic saline and he injected it in different parts of the shoulder and asked his medical students where their pain was. And if somebody has hypertonic saline in the subacromial space, they have pain along the deltoid, the lateral arm, sometimes under the arm. If it's in the AC joint, it tends to go up the trapezius, and if it's in the sternoclavicular joint, it tends to go up the sternocleidomastoid muscle. And so this can sometimes be helpful as well. Now, when we talk about the mechanism, acute traumatic rotator cuff tears are a different animal. They are high energy injuries. These patients will have severe immediate pain. They'll usually go to the emergency room thinking they fractured their arm and they'll get negative films. They'll have a severe immediate loss of function. They cannot lift up their arm. And that's a classic history for an acute traumatic cuff tear. Acute on chronic rotator cuff tears are kind of this hybrid. The energy that produced the trauma might be minimal, a fall from standing. They have pretty bad pain. They might have a loss of function, but what's interesting is in these patients, after a few days, they start to feel better and start to move again. And the next slide. And that's a form of rotator cuff tear progression. Rotator cuff tear progression can happen, as Jay will tell you, because this is mostly coming out of his work. It can happen asymptomatically, it can happen with mild symptoms, or it can happen with an injury. And we know that when someone's cuff tear progresses, there's a statistically significant association with the development of pain. But the problem is the pain doesn't go up much. It goes up by a difference of 2.9 points, which is just above the minimally clinically important difference for the visual analog scale for pain. So they'll say, yes, I have a little bit more pain than I used to have, but it's not grossly abnormal when the cuff tear progresses. Next slide. And then when we look at the likelihood ratio, it would be really great if we knew someone had a cuff tear and we treated them with therapy and they did fine and they didn't have pain. It would be great if we said, well, if you have pain, that's a sign that your cuff tear is progressing, so come in and see me. So can we use pain as a guide to predict cuff tear progression? And the problem is, and this is Jay's data, the problem is the likelihood ratio is 1.7. It's not 25 or 30. It's not high. And the reason is because you can get cuff tear progression that's asymptomatic, and you can have people develop pain when they don't have cuff tear progression. So it confounds the data a little bit. Next slide. So when we talk about the physical exam tests, we have to divide these tests into things that are producing pain and things that are producing weakness. And there's a multitude of physical exam tests, and hopefully Peter Millett, I think, did your physical exam lecture, but the drop arm test, painful arc, Job's test, Fulcan test, impingement signs, the rent test, which many of you probably don't know about, which you're going to learn about, and lag signs. Next slide. So this is a review of all these different physical exam tests, and it's a systematic review we did. We looked at all these different things, hundreds of patients. If you look at the likelihood ratios, unfortunately, for most of the physical exam tests, the positive likelihood ratios are relatively small. Remember, the closer it is to 1, the less it changes the probability of having a disease. So if you look at the positive likelihood ratios and just march down that column, nothing's really great until you do the rent test. And there's only one paper that looked at that, and I'll talk about this in a little bit. But the rent test had can you go back, Jay? Sorry.
I'm sorry.
Thanks. But the rent test, which I'll show you in a little bit here, had the highest positive likelihood ratio. If the tests are negative, it's still not helpful for ruling out rotator cuff tears because, again, the likelihood ratios are relatively close to 1. So most of the physical exam tests that we do are not very helpful in predicting a rotator cuff tear. Okay, go ahead. Next slide. This is the rent test. This was described by Codman. I would guarantee most shoulder surgeons don't do this, but I do this in clinic at my thin patients. It's hard to do in heavier patients, but you're palpating for a defect in the supraspinatus. So you bring the elbow into extension and you internally and externally rotate it and put your finger right by the acromion and you feel for that defect. And that's called the rent test. And according to Eugene Wolfe, that's very predictive of a rotator cuff tear.
Hey, Jed.
Yeah.
Can I just ask you a quick question? Have you ever correlated that with ultrasound to see that that's exactly what you're feeling?
I have not. But that would be a great fellow study.
Yeah, it'd be interesting, wouldn't it?
Do you look at the other shoulder, Jed, typically?
I typically don't. I just do this and see if I can feel it. I'm still trying to get my sensation on it. So I'm feeling it and then going back to look at the MRI and kind of getting some self-validation on this. It's not, I do this as part of my exam, but again, I think exams are really not that helpful for finding rotator cuff disease, except for a few exceptions. And this is one of the physical exam tests that may be helpful. Lag signs are very helpful. Now, again, you're not reproducing pain, you're looking for weakness. And so these are helpful for finding large rotator cuff tears. The liftoff test, look at the likelihood ratio. If you have a positive liftoff test, it changes the probability by a factor of 30. The drop arm test, Job's empty can test, not so good. External rotation lag signs, internal rotation lag signs. The positive likelihood ratios are very high. The negative likelihood ratios are not that good. And what that means is if they don't have a lag sign, they still might have a cuff tear. But if they do have a lag sign, they're sure they've got a cuff tear. All right, go ahead, next slide. So these are all different lag signs. I'm gonna have Jay click on them just quickly. You can bring the arm out in external rotation. They can't hold it there with the arm at the side. This is the internal rotation lag sign. You can bring the arm up. That's for the subscapularis. They can't hold it there. The external rotation lag sign with the arm abducted. The drop arm sign, you can lift up the arm and the patient can't hold it up. These are all lag signs. They show profound weakness and they're very predictive of having a rotator cuff tear. Again, the problem is because the negative likelihood ratios are not that far from 1. If they can do these things and hold the arm out, they still could have a cuff tear. Next slide. What about combination of tests? People have looked at this. This is a study that was done by out in Baltimore at Johns Hopkins. They tried to look at all the physical exam tests and see if they could find something that works. If you have a painful arc, a drop arm sign, and weakness when you test their infraspinatus strength, the positive likelihood ratio is 15, which is pretty good. So that's something you can say, maybe if I combine these tests, I get more likelihood that there's a rotator cuff tear. Next slide. And then the reference didn't show up on this, but this is something Nitin Jain did with his study and his group. And basically, this is an algorithm where you take the feature like sex, male sex, go up, that's worth 20 points. Liftoff test, positive, that's worth 40 points. And you add up all these points and come down to the bottom where it says B, and then draw the line down from the points, and that gives you the probability of a rotator cuff tear. And in this work, the sex, external rotation strength testing, liftoff tests, and Job's tests were the ones that were more predictive of having a rotator cuff tear. Next one. So that's accuracy. What about precision? Well, the problem is we don't really agree. There isn't a lot of data on this, but we don't really agree when we do physical exam tests. This was a study that looked at a consultant, which is like attending, and then the register, which might be a fellow, and then a nurse. And that's in England, so they have different names for these things, but different levels of experience. And they did tenderness, painful arc, external rotation. And when you look at their agreement for most of the tests that they did, the agreement was not very good, except for the drop arm test and external rotation weakness. And other than that, not very good agreement when we do these physical exam tests. Next slide. So just to summarize the history and the exam, the history of trauma is really important. It will predict, as we talk about later, what you do with these patients. Pain is tough. Pain is not as helpful. The physical exam tests for pain are not that helpful. It may help if someone has pain that they may be developing progression, but that's not a gimme. The pain, as we'll talk about, does not necessarily correlate with the severity of the rotator cuff disease, and pain physical exam tests are not that helpful. Weakness, I think, is much more helpful. If you detect weakness on your physical exam, that's much more helpful in finding rotator cuff tears, particularly lag signs, but you may not pick up smaller tears because they won't have a lot of weakness. Precision is lacking, and it is experiential. The inter-observer agreement and intra-observer agreement was better for the attending than it was for the fellow than it was for the nurse. So experience is very important here. And overall, and this is a segue into Jay, imaging is your best friend if you're looking for rotator cuff tears.
So you're saying that when my fellow's exam and my exam don't agree, that's pretty normal, Jed?
That's expected,
Okay.
and that always happens.
All right, so I'm going to talk a little bit about imaging. As we know, being orthopedists, imaging starts with radiographs. The classic 4-view series is what I typically obtain in the clinic. So the image on the left is your AP view, which is shot AP to the chest with the arm in a sling position. And this shows you a good image of the greater tuberosity, especially the posterior aspect of the greater tuberosity. The most helpful view is the true AP view, or the image on the right. And I call this a weight-bearing view because typically the arm is slightly abducted and in neutral rotation. And by definition, your deltoid and your rotator cuff are firing. So this is the analogous to the weight-bearing view of the knee. Other views are the outlet or the Y view, which can show you some acromial features. And then the axillary view is helpful to rule out arthritis of the glenohumeral joint and to look for osteochromials, which are sometimes relevant in cuff patients. You can get some clues for cuff disease just based on the x-rays. So there's been some work out of Asia that shows that greater tuberosity, cysts, and sclerosis have a pretty high predictive value in determining the presence of a degenerative tear. And then, as we know, acromial osteophytes are correlated with rotator cuff disease as well. Not necessarily the progression, but the presence of rotator cuff tears. Proximal migration is this phenomenon where the humeral head migrates from the unopposed pull of the deltoid. And this implies a loss of the force couple. And what you really need to know as a clinician is this implies infraspinatus disruption. So the more disruption of the infraspinatus, the more chronic the disruption, the higher the head migrates. So this is often measured by acromial humeral interval. I like to look at the symmetry of the joint space. A thinner joint space superiorly compared to inferiorly usually signals early involvement of the infraspinatus. This is relevant because if you have Hamada 3 changes, which means chronic wear between the tuberosity and the acromion, no soft tissue procedure works. Whether you're thinking about a cuff repair, a tendon transfer, or even an SCR, when you have Hamada 3 changes, you start thinking about arthroplasty. These x-rays are from the same patient. This illustrates the difference between an AP view and the weight-bearing true AP view. You see no significant migration on the image on the left, and then as soon as the deltoid fires, if your infraspinatus is out, you lose that acromial humeral interval. When do we do soft tissue imaging? So I think most would agree that if you have an acute traumatic event with weakness, that's an indication to image the shoulder. For degenerative rotator cuff tears, a lot of times you can manage them non-operatively, especially if the strength is maintained. And in many instances, the insurance companies won't authorize a MRI or advanced imaging unless they failed some type of non-operative management. The most common studies that we use, as you guys know, are MRI, CT arthrogram, and ultrasound. MRI is probably the gold standard. It allows you to visualize all soft tissues, gives you information on the tear size and location, muscle degenerative changes, and potential repairability of the tear. I think it's really important for us as clinicians to learn to read our own MRIs. We're different than radiologists. We actually get to listen to the patient and examine them, and we can interpret the MRI findings in the context of the clinical presentation. So that's really important in decision-making and managing your patients. MRI shows you anatomy in fine detail. Typically you have coronal, axial, and sagittal slices. You should look at all of the planes. Be familiar with the different signal sequences. Your T1 images are fat weighted, and they're really good for looking for muscle atrophy. T2 images are water weighted, so they show edema. It's really helpful to find areas of inflammation, effusion with T2 signals. And then proton density and stir sequences are commonly used. And these give you different anatomy depictions based on differences in water and proteoglycan content. MRI arthrogram is very helpful, especially for partial tears and labral tears. It improves the accuracy of those tests. I tend to do ultrasound a lot. If I have a younger patient that has an exam that's not quite straightforward, I think an MRI arthrogram is more helpful to delineate cuff disease and from labral tears, basically. When you look at MRI grading, we typically do this on a sagittal image. You want to look at the slice where the coracoid base and the scapular spine meet the glenoid vault. By MRI, you have a modification of the Goutallier system called the Fuchs grading system. And it's important to remember that you don't see muscle changes in the rotator cuff unless you have a full thickness tear or a neurologic problem. So partial thickness tears do not really lead to muscle degeneration. So stage 1 changes are, very slight atrophy. Stage 2, you see some fatty change, but there's more muscle than fat. Stage 3 is kind of the breaking point or the equilibrium where you have equal muscle and fat. And then stage 4 is advanced disease with more fat than muscle. MRIs are very helpful for what Jed described as the acute on chronic tears, in my opinion. This study by Marcus Lowe is one of my favorite studies of all time in helping distinguish acute injuries from chronic tears. And the important take-home point is that retraction of the tendon is not helpful. So you can have, if your cable's disrupted, your tear will migrate medially, and it doesn't tell you anything about the repairability or the age of the tear. So what you're looking for is muscle edema, subacromial fluid. And a lot of times you will find a wavy or a kinked infraspinatus tendon. And importantly, you don't see significant high-grade atrophy of those involved muscles. So I look for those 3 characteristics: excessive fluid and edema, a kinked or wavy tendon that's not short, and the absence of high-grade muscle degeneration rather than retraction. Another pathognomonic sign of a acute injury is when there's a stump of tendon left on the greater tuberosity. So this was first described by Ken Yamaguchi and Sherry Tifi on an ultrasound study, but usually chronic tears, the synovial metalloproteinases tend to degrade the tendon, and the tuberosity is bald. So when you see a stump of tendon left on the bone, that's usually an acute injury. Ultrasound is a great study to use, I think, especially for research purposes. It's very user-friendly, it's inexpensive, it's very helpful in revision cases, and in some studies more accurate than MRI in revision cases. They're ideal for patients who have metal or pacemakers. The disadvantage is experience really counts. So I'm spoiled here. I have radiologists that are adept at using ultrasound. It's not great for partial thickness rotator cuff tears. Neither is MRI without arthrogram, but I think you drop off on your accuracy for partial tears. And one of the things that surgeons have a tough time dealing with is you really can't see it yourself. So there's a leap of faith in trusting the radiologist sometimes when you're using ultrasound. And it's not great for muscle grading, especially the subscapularis. It's pretty good for infraspinatus and supraspinatus, but it cannot see the subscapularis very well. So these are some OR pictures and ultrasound pictures of a rotator cuff tear. You can get precise linear measurements of the length which is the coronal plane dimension of the tear and the width from ultrasound. So in summary, with imaging, I think the exam, at least in my hands, the exam is accurate to tell me if this patient has cuff-based pain. But as Jed said, you need imaging to make a diagnosis in the absence of weakness. The most important physical exam finding for me is external rotation weakness. You need to understand when to image and what to order, and learn how to read the images yourself, because the imaging can help dictate treatment, especially for more severe injuries.
All right, so I always get the short straw and get to talk about non-operative treatment for cuff tears. And so one of the points I wanted to make to you folks is rotator cuff disease is extremely common. There are a number of studies, and this was a systematic review at the bottom, that looked at the prevalence of rotator cuff tears, full thickness rotator cuff tears in people over 60 using ultrasound, MRI, cadaver studies. And it's somewhere between 10 and 40% of people over 60. In 2010, the US Census was 57 million people are over 60 years of age. And if you use a conservative estimate of 10% of those people have cuff tears, that's 5.7 million cuff tears in the United States. That is a huge number. What that number means is if every single orthopedic surgeon in the United States did nothing but fix rotator cuff tears, it would take about 4 years to get through all of those patients. There are 270,000 cuff repairs done in the United States each year. And so if you do 270,000 over 5.7 million cuff tears, the reality is that we're operating on less than 5% of all the rotator cuff tears that are out there, which tells you that they don't all need to be fixed. When I finished my training in 1994, what we were taught was if they come into your office with a shoulder pain and a rotator cuff tear, they need to be fixed. Clearly, that's not the case. Next slide. We know that there's a lot of geographic variation in how people approach rotator cuff tears. This was a study done by Evan Flato's group years ago, but basically in Mississippi, there were 9 cuff repairs per 100,000 Medicare patients, and in North Dakota, there's 85 rotator cuff repairs per 100,000 patients, a 10-fold difference. So what that points out is there's a lot of variation, that surgeons don't practice the same way in the same locations. Next slide. Warren Dunn did a survey of the Academy members. He got a 49% response rate. He gave them different hypothetical rotator cuff tear cases, and there was a lot of variation in how the surgeons approached those patients, and a lot of variation in how they expected the patients would do after their treatment. So, and again, that tells you that there's really not a consensus on who needs surgery and who doesn't. Next slide. If you try to go to the literature, there's 2 systematic reviews that have been done. It's been not great evidence, it's level 3, but in general, when they look at the data that's out there in the literature, these authors came up with the recommendations that acute tears probably should be repaired, and that weakness or functional loss was a good indication for cuff repair, because people with that whose cuffs heal do better. But pain is not clear. The atraumatic cuff tear with pain is not clear. Next slide. There's some other evidence to suggest that non-operative treatment may be helpful. When you do a cuff repair and it fails, it's very hard to distinguish that patient from someone whose cuff repair healed. There are a number of studies in the literature that looked at that question. Do people who have cuff repairs that heal differ from people whose cuff repairs failed? And there are a number of systematic reviews and meta-analyses out there, and what they have found is that both patient groups are satisfied. The patient-reported outcomes are the same, they're not different. But if you look at strength, strength is better if the cuff repair heals, and that makes sense. Next slide. We tried to look at this in some of our MOON data, and we tried to look and see how the anatomy correlates with symptoms. And basically, we had about 500 patients who had full thickness atraumatic rotator cuff tears. And we assumed that people with larger tears would have more pain, would have longer duration of symptoms, would have lower activity levels. Not true. The anatomy did not correlate with pain, duration of symptoms, or activity level. Pain did correlate with mental well-being, but not with the anatomy. And so that again, when the patient walks into your room and says, I have shoulder pain, and they have an MRI that shows they have a cuff tear, we make the assumption that the cuff tear is the cause of the pain, and I don't know if we can make that assumption accurately. Next slide. So our MOON study had 443 patients. So actually, we had a total of 550. but we had data at 5 years on 443. So they were all treated with physical therapy. Anywhere along the way of their treatment, they could drop out and have surgery. And this is a survivorship curve on the left. So patients who had surgery, it drops the curve down. And so what we found is that patients who decided to have surgery usually did so within the first 12 weeks. And after that, the rate of surgery was actually fairly low. At 5 years, we lost 16% to follow-up, 3% of our patients died, 24% of the patients had surgery, and 1 of those had a reverse arthroplasty. So what you can say from this data at 5 years is that physical therapy treated 75% of the patients successfully, and that your chance of dying is higher than your chance of needing a reverse arthroplasty.
That's great.
At least in 5 years. We're going to have 10-year data probably in the next year because we'll be done with the cohort in March.
Hey, so Jed, do you remember what the average tear size was in that study? Was there a wide range, or were they? Did you narrow them down?
Yeah, it was a wide range, and tear size did not predict the need for surgery.
Okay. Because I mean, these patients that we treat with massive cuff tears or cuff tear arthropathy, their cuff tears start somewhere. So I mean, these tears evolve in some patients to advanced disease. You're just not seeing that at 5 years, you think?
Yeah, it's hard to predict. Again, if 95% of the people out there with cuff tears aren't needing surgery, most people do pretty well. But we have to figure out who is not going to do well, and then we have to decide and know, is our surgical intervention, if I fix someone with a medium cuff tear, is that going to change their natural history? Or is that the guy whose cuff tear is going to fail anyway, and then they're going to develop cuff tear arthropathy down the road? There's still a lot of data we need to get.
Hey, Jed and Jay, can I just interrupt for 1 second? Because one of the things you guys haven't mentioned, and I think you've kind of been circling around it, and the way I think about it, Jed, is that you're explaining exactly the way I think, but you're just not saying it, which is that the pain comes from the associated bursitis. The pain does not come from the rotator cuff unless it's an acute tear. And so that's the reason there's so many atraumatic rotator cuff tear patients, is if they don't happen to have an inflammatory bursal condition, then they don't present with pain. And unless they have significant weakness, they don't show up in our office. And so I agree with you. The physical exam findings that you're questioning, the ones that relate to strength, are the ones that are most reliable. I don't use pain as a judge of whether there's a cuff tear or not. I use pain as a sign of whether they have an inflammation in their subacromial space, their AC joint, their SC joint, or wherever their pain may be.
Yeah, I mean, I'm not going to disagree with you. You basically are making my argument for me.
Yeah, I think it all boils down to, though, we can't, as Jed said, we can't predict those patients that do get those inflammatory bursitis problems. So it'd be interesting to see if you looked at the Moon Group patients that actually had weakness on their exam, Jed, the external rotation, if they had a different, I mean, obviously they're not failing and going to reverses, but I'm wondering if they're losing function over time, or if their deterioration is more pronounced than the cable intact smaller tears.
Hopefully we'll be able to get some more data out of this cohort at 10 years. So I'm going to keep moving on with this. So there are 3 randomized trials that looked at surgery versus non-operative treatment for cuff tears. The Moose-Mayer, and they're all not done in the United States, interestingly enough, but the Moose-Mayer trial in 2010 had 103 patients, 52 were treated non-operatively, 51 had surgery. And if you break it down and look at the failures of treatment, the failures of physical therapy, 18% of the non-op group crossed over and had surgery. When they looked at their MRI imaging of their cuff repairs, 24% of their cuff repairs failed. Interestingly, in their group, and something that's important, is in the surgery group, 35% of those people had biceps work. And we know the biceps can be a pretty significant pain generator. And so that definitely influences the result of surgical treatment in this cohort. The patient-reported outcomes favored surgery group because they used the constant score, which is interesting. The constant score is really the only patient-reported outcome that measures strength. And so the constant score was better in the patients that had surgery. But if you looked at their pain levels and other things, they weren't that much different. Kukkonen did another study in 2014. This was interesting. 3 groups: home therapy, subacromial decompression, PT, no treatment of the torn cuff, rotator cuff repair, subacromial decompression, and PT. And 1 year, no difference in the patient-reported outcomes. they had about a 10% crossover rate to having surgery in the therapy group. And here Spink had 56 patients. Some were treated with mini open rotator cuff repair. Some were treated with an injection and physical therapy. Again, they saw about 10% of patients treated with therapy crossed over and had surgery, but they had a lot of failures of their rotator cuffs. And again, they had statistically significant, but they didn't reach the minimum clinically important difference for their patient-reported outcomes comparing the groups. But again, 42% of their rotator cuff repair had a biceps tenotomy, which could definitely skew the results towards surgery. Next slide. So here's a summary on non-operative treatment, and Bill was kind of stealing the thunder a little bit. Things to remember are that 95% of the cuff tears don't get surgery. If you do a repair and it fails, patients are happy. I don't know if that repair really did anything. It's probably the post-operative therapy that made them better. Non-operative treatment is successful in about 75% of patients overall. Surgical treatment, if you just define success as your repair healing, is successful in about 75% of patients overall. Pain does not seem to correlate with the anatomy of the rotator cuff. Weakness and functional loss then may be a better indication for surgery. And as Jay can teach us about progression, we know that progression is associated with pain, but we can't use pain to predict progression. So it makes it difficult. We don't know who's at risk for progression. We don't know if somebody progresses, are they going to have problems? And we don't know if I do surgery on a patient, are they still going to get a cuff tear and fail later? And is that going to change the natural history? We all hope it does. I think it probably does, particularly in small tears, but I just don't know.
Yeah,
Next slide.
that's great data. Just a couple.
Jay, before you move on, there is a question that came from one of our fellows about the MR arthrogram. So the question was, if you have a patient that had pretty much unremarkable non-contrast MRI, have you found that then getting a contrast MRI has ever helped you? That's his question.
I think more often than not, the MRI that I am going to repeat is the one where the initial quality wasn't very good. So, and that's where the MRI arthrogram has helped me. I think with modern imaging sequences, a lot of times the non-arthrogram MRIs are excellent even for labral tears. But I see a lot of patients from rural Missouri, and the MRI scanners aren't always the best quality. If I have a younger patient and their exam's a little bit equivocal, I think an MRI arthrogram is helpful in that case. So
then a question came up for Jed. You know, Jed, you were very articulate about why not to treat them with surgery. The question is, how do you do that non-surgical treatment? How do you rehabilitate those patients? Can you, Jed, tell us what your protocol is for physical therapy, home therapy, injection, yes or not? Just in 2 seconds, you know, what do you do to treat them?
Yeah, 2 seconds. Go to www.moonshoulder.com and you can download the protocols. We did a systematic review of the literature that was in the therapy literature to look at what physical therapy protocols were effective in treating rotator cuff pain. We got all the literature. We extracted the exercises the therapists were using and created a protocol, and that was our Moon protocol. And that's available. It's at moonshoulder.com. All of our therapy protocols for all of our studies are just out there, so you can download them.
So for the fellows, that is a great resource. So this weekend, if you have time, go to the website, and then you will see exactly what Dr. Kuhn developed as the ideal treatment protocol for these patients. Thank you so much.
Yeah, one brief comment. We do use injections, but the way I think about an injection is if somebody comes in with a lot of pain, the injection is a catalyst. It's not the treatment, but it may decrease their pain to make therapy more successful.
I agree completely with that. They do rehab better. I think a couple quick comments. One of the most important questions that Jed has asked is, will surgery change the natural history? And that is largely unanswered. So if you look at most studies have, as you know, 2 or 3 year outcomes, and the healing rates, if you pool all the data, there's a 20 to 25% re-tear rate. So there are 2 studies done from France with Philippe Collin as the author that looked at the long-term structural results, not just the clinical results. And these were isolated supraspinatus tears. And there was a lot of attrition, but in the patients that they were able to get back, the re-tear rate at 10 years was 19%. So these were people that were healed at 1 year and they re-imaged them later. Re-tear rate was 19%, and that number jumped to 40 or 50% by 20 years. So there is some data that with small to medium-sized tears, you can get a durable result, but there is a re-tear rate that tends to happen over time. Not in everybody, but at least 20% of the time at 10 years.
Just a quick time check. We have 15 minutes left.
Okay, so surgery, just so quickly, we're going to talk about some technique pearls. Importantly, indications are really important. I think I manage most degenerative tears conservatively, even the ones that I deem higher risk. The ones that are higher risk, I do tend to watch them a little more closely. One of the most fundamental questions is, what is an irreparable tear? So as I mentioned before, if you have Hamada 3 changes, there's little debate that a soft tissue procedure doesn't really work in those patients. Other commonly described criteria, although Steve Burkhart may argue with this, would be a tear that involves 2 or more tendons that has grade 3 or 4 muscle atrophy, patients that have fixed tendon retraction, patients that have severe tendon loss. So if you look at some of these chronic tears, the stump of the supraspinatus is sometimes less than 12 millimeters. So those are very difficult to fix. And then all of the tear-related features that predict healing have to be factored in, have to be weighed against the patient's age, because age trumps everything in terms of cuff healing. So what do we know about cuff repair outcomes? Well, I'm going to disagree with Jed just a little bit. I think healing does matter, not in everybody, especially my older, lower demand patients. So both Bill Levine's group and our group tried to look at this, and there's a lot of psychosocial factors that are important. Bill's studies demonstrated, but we also demonstrated that younger age patients and patients with a higher demand job have a much worse outcome with a failed cuff repair. So probably in younger active patients, healing does matter. These are the 3 factors that affect healing the most. Age, under 62 to 65, healing is better. Beyond 65, healing is worse, probably 10 to 15 percentage points worse. Tears that are smaller heal better. So beyond 25 to 30 millimeters, you start to see a drop off in healing. And then when you see grade 3 and 4 muscle atrophy, those shoulders do not heal as well as 2 or less in terms of muscle atrophy grading. So your goals of surgery are to create a tension-free repair, try to recreate the tendon anatomy when possible, and address associated pathology, as Jed mentioned, such as the dreaded biceps tendon. So the steps are going to be identify the tear pattern, mobilize the tear, prep the tuberosity, and maximize the repair strength. So it's important to remember that when you're supra and infra tear, they don't just retract medially, they retract medially and posteriorly. So you got to bring the tendon lateral and forward to reduce it to the footprint. So let's talk about some common tear patterns. This is what you want to build your practice on, the beautiful crescent tear. These are so easy to fix. So in these tears, the size of the tear is greater than the retraction. Usually these are cable intact and they're easy to mobilize, easy to repair, and they often heal regardless of your repair construct. The U-shaped or the V-shaped tear, the retraction of the tear is greater than the size. Often these are cable intact, but they often require a side-to-side repair to lateralize the free edge and to avoid over-tensioning the repair or creating dog ears at the anterior or posterior margin of the tear. So this is a lateral view of a beach chair position of a right shoulder. This is a what I would call a V-shaped tear. So you cannot mobilize that edge to the bone without undue tension. So what you want to do is basically perform side-to-side repair, which effectively lateralizes the free edge, and then you can repair it to anchors down to the tuberosity footprint. L-shaped tears are also seen, and these tears are very anterior in location. So the anterior supraspinatus tears, and it propagates posteriorly into the footprint, but the anterior margin of the tear retracts medially. So in these tears, this is a view from the joint of a cable disrupted tear. You can see uncovering of the biceps tendon. This is the same shoulder from the lateral view. The IC is the interval capsule, the biceps, and then the supraspinatus. So in this shoulder, this is a perfect case for an anterior interval slide, which is a release of the coracohumeral ligament and the adhesions underneath and anterior to the supraspinatus tendon so that you can fully mobilize it. And then you have the reverse L-shaped tear. So this is the opposite of an L-shaped tear. So the anterior supraspinatus is intact, but the posterior supraspinatus tears and it cleaves away from the infraspinatus. So again, this is an indication for side-to-side repairs to lateralize the free edge of the tear, bring it closer to the tuberosity, and then you can perform your tuberosity fixation, in this case, a double row repair. What about tuberosity preparation? I think this is probably one of the more important aspects of healing. We know from ultrasound studies done out at JSES that the blood flow for a cuff repair comes from the bone and from the bursal side, but the tendon itself is avascular. So the actual substance of the tendon has a poor blood supply. So interestingly, this is one of the most understudied elements of cuff repair healing. So I would love to do a prospective randomized trial of no tuberosity prep versus tuberosity prep, but I don't know, it's not easy to do ethically because I think it's important. So Steve Snyder is probably the most influential person in describing this thing called the crimson duvet. You want to abrade the bone, create some bleeding, a nice bloody blush to repair the cuff tendon onto. The repair construct is often debated. The goals are to have secure fixation and minimal tension. Tension is the kiss of death for a cuff repair. So you want to use an adequate number of sutures and anchors to secure the footprint. And then there's the debate about single versus double row repair. Double row repairs do offer better strength. They give a larger contact area for healing. They have better healing rates, but the clinical outcomes really aren't any different than a single row repair, at least in most studies. And they're more expensive. And if a double row repair fails, it's a difficult revision because a lot of times it fails at the medial row and you're left with a very short tendon to repair. I'll tell you, when I use a double row repair is when I think that I can overcome some limitation in biology with the repair construct. So for me, these are older patients, not necessarily old, but over age 55 to 60, larger tears, so larger than 2 centimeters in the sagittal plane, and poorer quality tissue. So these are thin or delaminated tendons. You want to avoid excessive lateralization with those. So sometimes if I can't pull it all the way over, I'll do a single row repair with multiple anchors. Single row repairs are great for smaller tears in younger patients. The sweet spot would be a partial thickness takedown and repair, and they perform very well in most clinical series. This is an inverted mattress tension band suture described by Pascal Boileau. And George Morrell in Australia has done a litany of research looking at these tension band repairs, showing really good healing rates and clinical outcomes. There's been a lot of studies looking at single row versus double row repairs, and I could quote a lot of literature. This is one of the better studies done by Peter Millett, looking at 7 level 1 studies. So these are prospective randomized trials showing almost a double re-tear rate with single row repairs, but no difference in clinical outcomes in these patients. Acromioplasties, my advice is be selective. I do them selectively when there's signs of mechanical abrasion. They're really not shown to affect the outcomes. There have been multiple prospective studies comparing cuff repair with and without acromioplasty and showing no difference in clinical outcomes, and be cautious with the os acromial. I think Jed's going to talk about irreparable cuff tears now.
Okay, next slide. I'll just spend a couple minutes very quickly because the bottom line is we don't really know what to do. So when I was young, if you saw this guy in clinic, I'd say there's no way therapy would help him. But believe it or not, he did better with therapy. So we put his hand over his fist. He can raise his arm up and hold it up in the air. For me, that's a sign that he may do well with physical therapy. This is a protocol that was developed by Ofer Levy that you can download and look at it. And sometimes patients with pseudoparalysis will get better with therapy. Next slide. You can do an arthroscopic debridement described by Charlie Rockwood many years ago with Jerry Williams, Buzz Burkhead, and All-Star Cast. That includes debriding all the loose edges, getting rid of that bursitis. Fenlon described a tuberoplasty. The natural history of rotator cuff disease with massive tears is that the tuberosity goes away with time and turns smooth and round. And of course, with massive tears, you can do a biceps release or tenodesis as part of the debridement. Next slide. You can do partial repair. Stephen Burkhart was popularized this. The goal is to try to restore that crescent. Even though you can't get the cuff repaired completely, you can repair what you can. Next slide. You can do a graft augmentation, which is usually some form of collagen graft to fill the defect. That, you think this is new, but people were using Teflon and felt grafts back in the 1930s when they had irreparable cuff tears. Next slide. And then of course the superior capsular reconstruction that came out of Japan, where you actually take this graft and secure it to the superior glenoid with anchors. The reason this was developed, so all of you know, is that they did not have the reverse arthroplasty in Japan, so they needed to have something to do with these massive cuff tears. Next slide. And then of course there's tendon transfers, and there's all kinds of different ones. Sternal head of the pec for subscapularis, latissimus when the supra and infra are involved, lower trapezius for the supra and infraspinatus. That you can take the upper trapezius and move it under the acromion. The Japanese published on that. And you can do a pec minor for the subscapularis. They're not as popular, but they're out there in the literature too. Next slide. And of course, we all know about the reverse arthroplasty for the irreparable cuff tear. Next slide. And there have been trials of a absorbable balloon that fills with saline that depresses the humeral head, takes away pain. Patients do therapy, the balloon goes away, and patients feel better. This is not available in the United States yet, but it probably will be soon. Next slide. So what are the outcomes of all these different techniques? Next slide. This is a paper that's about to be published in the Journal of Shoulder and Elbow Surgery. Look for it and download it. It's a phenomenal systematic review that looked at all these different options for treating massive rotator cuff tears. Next slide. This is a table from that paper. As you can see, most of the papers are case series, sometimes level 3 studies, but there are very few comparative trials to look at all these different options for treating massive cuff tears, which is a problem. Next slide. This is the results in short, and again, you really shouldn't be comparing different treatments because there's too much selection bias. But anyway, therapy can improve the visual analog scale by about 3 points. It can improve the constant score, the ASES score. It can improve elevation. It fails in about 30% of people who go on to have surgery. Debridement improves the visual analog scale about 4.5 points. Both the constant and the ASES scores improve. You get gains in forward elevation. Partial repairs, same thing, but about 45% of those re-tear. Graft augmentation actually does pretty well. Huge gains that meet the minimally clinically important difference for the constant score and the ASES score, 20% re-tear rate. Superior capsular reconstruction, again, big gains in the ASES score. Failure is up to 12% in the literature. I think that's similar to graft augmentation. Tendon transfers, there's a lot of data on different tendon transfers, big operation, a lot of complications associated with it. But it does help some patients. And of course, we all know about reverse arthroplasty, but it's not perfect either. It has about a 10% failure rate and an 8% reoperation rate. So just be aware of those issues. And again, when this paper comes out, download it and read it. Next slide. Again, we can't compare techniques. The studies just weren't designed to do that. There's a lot of selection bias and performance bias. So just look at that data, put that in your mind. The bottom line is when it comes to the massive irreparable cuff tear, you have to have a lot of tools in your belt, and then you got to know what patients need which approaches. And that right now comes from experience. I'll tell you about something exciting coming up in the future that might help guide you with this. But some patients would do better with a muscle transfer. Some patients would say, there's no freaking way I'm going to transfer a pec on this guy, but I'm going to debride him instead. Every patient's different. You got to know what the indications are for each approach. Next slide. So how do we help you with that? Well, the Near Circle is a group of shoulder experts in the Shoulder and Elbow Society. And we're doing right now, right this minute, a Delphi method trying to develop consensus on scenarios for massive cuff treatment. And we've sent out questionnaires to people. They've come back and told us what they want. We're looking at the data. It's not ready for prime time yet, but there's a few things that have come out of the data early, and that is reverse arthroplasty would not be indicated for people less than 50, and it's preferred for people over 70, and superior capsular reconstruction would be preferred in people less than 50 and would not be indicated in people over 70. We'll have more data in the future. That'll come out probably in the next 6 months or so. Next slide. And that's all I had. Thanks for your attention, guys. If you have any questions, let me know. There was one question about physical therapy that somebody asked, and when do we offer surgery if somebody's not getting better in therapy? And for me, what I'll do is if somebody's complaint is pain, not weakness, not functional loss, I'll have them try physical therapy, particularly if they're older. I'll give them 6 weeks. By 6 weeks, they declare themselves. They say either I'm getting better, I like the therapy, let's keep going, and then by 12 weeks, they're usually in pretty good shape. Or they come back at 6 weeks and say, doc, this isn't working. I just want to get it fixed. And then we talk to them about surgery. Patient expectations drive these decisions. And if a patient does not think therapy will work, it's almost pointless trying to make him do it. If he thinks I want an operation, he won't get better unless he gets the operation. You can try to influence that, but if a patient wants an operation, they're not going to get better unless they get the operation. I hope that helps.
Well, thank you, Jay and Jed. That was a masterful, great review of all the options. I don't know if Bill or Ranjan have any additional questions or comments. Nothing came from the fellows recently. Any questions, anyone?
Time's up.
Well,
Great job, guys.
Yeah, thank you very much again. And thank you to all the fellows for connecting tonight. We've had more than 32 fellows connected. So we'll see you guys next week. Thank you.
Thank you.
Thanks, guys.
Thanks, Jed.